Welcome everyone to the Canadian Nurses Association's webinar series, Progress in Practice. This webinar is entitled An Evidence-Based Review of Opioid Agonist Treatments and What They Mean for Nursing Practice. This session is being recorded for nurses who are unable to participate today. My name is Carrie Schuhendler. I'm a registered nurse and policy advisor at the Canadian Nurses Association, and I will be hosting this webinar. At the end of the presentation, we will answer your questions, which you can type in the Q&A box that you see on the right of the slide. We will address as many questions as time allows. After the webinar, we will email you a link to the recording and a short evaluation. Once you've submitted your feedback, you'll be redirected to the certificate of participation. And now a little about our presenters, Al Fowler and Cheyenne Johnson. Al Fowler is originally from the Kootenay region of British Columbia and has spent most of his time in Vancouver. He has been a community activist and member of the BC Association for People on Methadone for 5 years and has been working toward improving the lives of people who use opioids. Al is currently president of the BC Association of People on Methadone. Cheyenne is a clinical and research leader at the British Columbia Centre on Substance Use. She holds a degree in nursing from Queen's University and a master's in public health from Simon Fraser University and is a certified clinical research professional. Cheyenne is also the director of the British Columbia Centre on Substance Use Addiction Nursing Fellowship and is an alumna of the program. This webinar is number 2 in a 5-part series entitled Substance Use Trends in Canada, What Nurses Need to Know. If you are interested in the other webinars in this series, please visit our website. Now I'd like to hand it over to Cheyenne and Al to dive into today's topic, an evidence-based review of opioid agonist treatments and what they mean for nursing practice.
So good morning, everybody, and thanks so much, Carrie, for that introduction. So it's Cheyenne here, and I'm going to take us through the first part of the presentation and then hand it over to Al. So just a note to start, there's no conflicts of interest from either of the presenters today. So today we're going to be discussing an overview. We'll review the new BC Centre on Substance Use Guidelines for the treatment of opioid addiction and really focus on the continuum of care that exists for opioid use disorder or opioid addiction. I'm going to highlight a number of key roles that nurses will play and implications for practice. And then we're going to speak with Al, and he's going to give a patient perspective on opioid addiction and opioid treatment. So this is the framework that we're going to use to guide the presentation today. So the first piece we'll talk about is knowing the evidence. So in February of this year, these new guidelines, which are the BC Centre on Substance Use Guidelines for the clinical management of opioid use disorder, were released. And these are really the only kind of guidelines like this, actually in the world, that really look at opioid use disorder along a continuum of care and best evidence. There's a number of clinical guidelines that exist out there for healthcare professionals, but they mainly focus on methadone, or they focus on buprenorphine, and this one looks at really all different treatments along a continuum of care. And a note that later this year, through a CIHR, Canadian Institute of Health Research funder, a new national network exists called CRISM, which stands for the Canadian Research Initiative in Substance Misuse, is actually taking these guidelines and developing them into a national guideline for Canada. And so the map there just shows the different CRISM nodes across Canada and sort of a placeholder template for what the guideline might look like, but just keep your ears out for that. That's going to be coming in the summer of 2017. So the BC Centre on Substance Use Guidelines use this diagram, and we're going to kind of walk you through it today. It's quite novel, again, as I mentioned, as it really outlines a number of different treatment strategies for opioid use disorder, starting with withdrawal management around a lower intensity level of care, all the way up to specialist-led approaches. So let's start by reviewing withdrawal management approaches. So it's really important to note that withdrawal management approaches, or commonly referred to as detox, can be a really important first contact to bridge people into care. For opioid addiction, however, when we combine, when detox is provided as an isolated intervention for opioid addiction, so by that I mean people go into withdrawal management facilities, they do a short taper off of opioids, and they're kind of left, leave the door, it closes behind you. When that type of treatment intervention is done, it leaves patients really particularly vulnerable to several serious health harms. So abruptly stopping and tapering off opioids results in the vast majority of individuals to return to opioid use. In fact, up to 90% of people will relapse within a week of discharge. And some of those health concerns that I mentioned are really increased rates of HIV transmission and morbidity and mortality related to overdose or non-fatal overdose. Additionally, studies have shown that in comparison to offering nothing, persons who ingest drugs who undergo withdrawal management, again, are likely to contract those medications, contract HIV or hepatitis C, likely as a result of those high-risk behaviors upon relapse. And take-home naloxone or naloxone training should really be provided as a nursing intervention for people that choose to go on short tapers. So when we think about psychosocial treatment interventions, and this is again within the withdrawal management strategy framework, what benefits do they have when provided with withdrawal management only supports? So again, when I say psychosocial treatment interventions, I mean things like contingency management or cognitive behavioral therapy or psychotherapeutic counseling. When they're provided in conjunction with withdrawal management approaches, they do appear to be beneficial, again, as an adjunct. But one of the issues is there's really no evidence on the best approach. So we don't know if contingency management or cognitive behavioral therapy is really the best approach. So really with psychosocial treatment interventions, the best practice is really to have them available for clients that may want them, but not to make them a barrier to accessing treatment. And so what about residential treatment? If we look at the evidence, it's really difficult to actually demonstrate the effectiveness of residential treatment alone. There are some signals that residential treatment may lead to some clinical improvement, but this is really an area where a lot more research needs to be undertaken to look at characteristics, effects of who is best to go into a treatment program, and really might predict appropriateness for referral and outcomes of treatment. Again, that's not to say that residential treatment doesn't work or is ineffective. We really just need a lot more research in this area. It's also really important to note that relapse is really common among residentially treatment patients with opioid use disorder. Some studies showing 91% of relapse, and about 59% of that was actually in a week of discharge. Similar for the psychosocial supports and nursing considerations for this treatment modality really include a thorough history, obviously including financial considerations for what people can afford for private versus publicly funded treatment, and really being aware of resources in your area and somebody that can assist. For those that are familiar in this area, residential treatment and getting into programs is you kind of need to be an expert in the area. They have a number of different inclusion and exclusion criteria based on medications that people are on. So really having a social worker or another allied health professional to navigate this is quite important. So we'll move on to the sort of moderate intensity treatment modality, which is opioid agonist treatments or agonist therapies. And this is really the area that we have the strongest amount of evidence for successful long-term stability. So what does work for opioid addiction? People on the line are likely familiar with methadone and or a newer medication in Canada called buprenorphine naloxone, which has been around for just about 10 years. These medications are generally dosed daily, and when dosed correctly, these medications can help to alleviate withdrawal, cravings, and euphoria associated with opioid use. They have been shown very effective in retaining people in treatment and reducing illicit opioid use. Methadone has been the most commonly prescribed medication for opioid use disorder up until now. It's been around for about 40 or 50 years. It's liquid. It must be administered by daily witnessed ingestion from a pharmacy or a clinic. So let me just take you through kind of some of the advantages and disadvantages for both of the medications, which can be a helpful guide when talking to patients or counseling them and thinking about what treatment options might be the best. So let's start with methadone. So on the advantages side, it might be better. Some of the research indicates for treatment retention, particularly for unstable opioid-dependent individuals. It might be easier to initiate treatment, and we're going to talk about that when we talk about buprenorphine naloxone, because with that medication, you need to be in a moderate opioid withdrawal in order to start. With methadone, people that are interested in starting treatment can go see a prescriber and leave with a script that day and start the medication that day. There's no maximum dose for methadone, so it can be titrated according to what patients need. There's no risk of precipitated withdrawal, which again is something that I'm going to talk about when we review the mechanism of action for buprenorphine naloxone. It could potentially be a better alternative than Suboxone or buprenorphine naloxone if that medication was unsuccessful in relieving withdrawal symptoms, or people had some side effects related to using Suboxone. We'll talk about this again, but because of the mechanism of action between both of the medications, it's much easier to try people on Suboxone first, and if that doesn't work, then to move up to methadone rather than the other way around. It's much more tricky. It's also approved in Canada to treat opioid use disorder, but also for analgesia. So people that have addiction and chronic pain may benefit from this medication because you can do split dosing, so twice a day or 3 times a day. But we should note that in Canada, you still need an exemption as a prescriber to have this medication. Some of the disadvantages are it's a higher risk for overdose, so it's a full opioid agonist. So it acts just like morphine and heroin and other full agonists in that respect. And in British Columbia in 2015, we have some data where 25% of the overdoses people had methadone on board. Again, it generally requires that daily witness ingestion, which requires people going to the pharmacy every single day, which is really a drag, but also it's a drag on our healthcare system. It's really expensive. In addition to the fee that people get for the dispensation, some provinces also provide a daily witness fee for the pharmacist to actually ingest, and so it can be quite an expensive medication. It has a more severe side effect profile when you compare it to buprenorphine naloxone and other opioids. And a lot of my physician colleagues actually describe this as the warfarin of addiction. And it can interfere with a lot of common medications that are used to treat people who use drugs. For example, people that have tuberculosis and medications to treat that, antibiotics and antiretrovirals. So it really needs to be titrated very closely, especially in acute care settings and when people are in the hospital. A major disadvantage, in my opinion, of methadone is that it takes a long time to achieve a therapeutic dose. So this can be more than 35 days, and this is like with perfect adherence. So this is with somebody coming to the doctor every week to get their dose increased slowly, slowly, slowly. Because of the very, very long half-life of methadone and the way people metabolize it so differently, you have to kind of start low and go very, very slow up to the targeted dose. So that can take a really long time, which can be very, very frustrating for patients and providers because they're still having withdrawal and craving, and in those early days, it's not actually treating those symptoms. I mentioned the higher potential for drug-drug interactions and with a severe side effect profile. And one other piece is increased cardiac arrhythmias related to QTc prolongation with methadone. So let's compare that to the advantages and disadvantages of buprenorphine naloxone or Suboxone. And you'll probably notice right off the bat that the risk of the advantages list is longer and the disadvantages list is a bit shorter. So let's take you through those. The top one is there's less risk of an overdose. Because buprenorphine naloxone is actually a partial opioid agonist. So unlike methadone, which is that full agonist, it actually has a ceiling effect. at a particular dose. And for buprenorphine naloxone, that's around 32 milligrams. So it actually is a bit protective against overdoses. We know from some data in New York in a number of years ago that the methadone overdose implications were quite higher. Out of about 1,000 overdoses, there were only about 2 that buprenorphine might have been on board there. There's also a decreased risk of injection. Again, buprenorphine naloxone or Suboxone, the way that we have it in Canada, is co-formulated with naloxone, which is an opioid antagonist. And so the reason that it's actually in there, and this is a common question that I get from patients all the time, is it's in there to actually reduce the risk of injection. So if you crush it up and inject it, then if you have opiates on board, then you'll go into what we call a precipitated withdrawal. But if you take it as it's indicated, which is sublingually, so under the tongue and fully dissolved, the naloxone component is not actually bioavailable. And there's also a less of a decreased risk of diversion, again, because of that naloxone component, although we are hearing more and more that buprenorphine naloxone is readily available in the illicit market on the street. But here in Vancouver, I hear it from a lot of people that it's actually being used to treat their addiction, so they'll use it to treat withdrawal symptoms. It also allows for safer take-home schedules, again, because of the better safety profile of buprenorphine naloxone and the new Health Canada product monograph. You can actually start on a safer take-home schedule much, much easier and earlier than you can with methadone, which is a huge advantage for patient autonomy and not having to go to the pharmacy every single day. Again, it has that milder side effect profile. It doesn't interact with as many antibiotics and ARVs and other medications compared to methadone. We talked about this a little bit, but it's so much easier to rotate from Suboxone to methadone because Suboxone is that partial agonist and methadone is that full agonist. It's much easier to switch around, and it's quite challenging to convert from methadone to Suboxone. We talked about the flexible take-home dosing schedule is cost savings, but also patients like it much more rather than going to the pharmacy. And it's really a big advantage for me is that super short time to achieve a therapeutic dose. So you'll remember we talked about 35 plus days for methadone. For Suboxone, it can be 1 to 3 days. So super, super quick, and people feel really, really well, and cravings and withdrawal are treated quite quickly. Some of the disadvantages, some of the earlier studies showed that there might be an increased risk for dropout or patient retention. Some of those studies, people weren't really adequately dosed, so people were on sort of 8 to 10 milligrams a day. And from some of the best evidence we know with Suboxone, people should be on about 12 to 16 milligrams per day for it to have the maximal therapeutic effect. It may cause precipitated withdrawal if it's induced inappropriately, and this is just kind of a real pain, and people that have done this will have precipitated withdrawal in a couple of people, and really what happens is, again, because of that opioid agonist, the partial opioid agonist, if it's given too early when people are not in enough withdrawal, then you actually precipitate that withdrawal, and it's so uncomfortable for patients, and they feel really, really terrible, and it can be quite challenging to get through, but we can talk about it later. There is strategies, and really the best way is for people to just ride it out and try to continue on with this medication because they will feel better in a number of days. Another disadvantage of it is it may block analgesics used for concurrent pain treatment, again, because it has that ceiling effect. So if people are in an acute pain crisis or they have a lot of chronic or acute pain on top of this medication might not be the best for them. And it's also not approved in Canada for the purposes of pain control, which is interesting because it's a medication that actually came from the world of anesthesiology. So I'll take you through sort of the highest intensity treatment approaches, or what we would call specialist-led approaches in the BC Centre on Substance Use Guidelines, and this is kind of the last stop. And I wanted to mention here, I'm going to mention injectable opioid agonist treatments as well, so injectable hydromorphone and prescription heroin or diacetylmorphine. But I wanted to highlight that the guideline that currently exists in BC is just an oral guideline at this point in time, but we are working on guidance documents for injectable treatments. So slow-release oral morphine, in British Columbia, we have this as the brand name Cheyenne, and it's a 24-hour oral formulation of morphine that comes in a capsule and it's kind of time release. There's a number of studies that have been done, and a Cochrane review, so the high systematic review or a high level of evidence that showed Cheyenne or slow-release oral morphine as a suitable alternative treatment, again, at that higher intensity, so when methadone and Suboxone might not really be working for folks. And so there needs to be additional evidence to support this, but some of the studies actually show similar retention in treatment to methadone maintenance, and newer studies signal to that slow-release oral morphine may be more beneficial in terms of methadone. Again, it's that increased safety profile. So for example, methadone compared to slow-release oral morphine, the slow-release oral morphine showed a shorter QTC interval. Patients reported less craving on slow-release oral morphine. Patients preferred it compared to methadone, and there were less side effects. Again, it's really important to note that this is a treatment option that's best for patients who are what we'd say treatment refractory, or those other medications just haven't worked for them for whatever reason. And this type of intervention should really be seen by addiction medicine specialists or somebody that has training in this specific area of medicine. So I wanted to touch on injectable treatments, and then first I'm going to start on diacetylmorphine, or sometimes commonly referred to as prescription heroin. Again, it's outside the scope of the document, but I think it's a really important piece of medicine and for nurses to kind of know about. Again, we have a Cochrane review from 2011, which is that highest level of evidence in a systematic review. Combined together, it shows the benefits of injectable opioid agonist treatment, or diacetylmorphine. Again, it's for that small group of patients that any of those other medications that we've talked about really hasn't worked for them. And so studies are supportive and show there's decrease in crime, there's decrease in illicit substance use and criminal mortality, a huge reduction in mortality, increases retention in treatment, and decreases interactions with the criminal justice system and rates of incarceration. There's also a lot of evaluations that have come out that show a huge cost savings and cost effectiveness for this, and again, that's primarily due to less criminal activity and incarceration. Although diacetylmorphine is available for the treatment of opioid use disorder for many years in other countries, it's not yet approved in Canada, and it's only currently available for a very small group of patients at a Providence Healthcare clinic called Crosstown, which is in the downtown east side in Vancouver. There's a lot of steps that are being taken nationally, as well as in the province of British Columbia, to really figure out how we can scale up treatment options, including diacetylmorphine. But one that I want to talk about, pardon me, is injectable hydromorphone. And so people on the line might be familiar with the Salome study, which was the study to assess longer-term opioid medication effectiveness. This is a phase 3 double-blind non-inferiority trial that compared diacetylmorphine to injectable hydromorphone. And so in this study, which is actually now the clinical model of care, so this moved from a study to an actual continuing clinical program in Providence Health, not without some challenges, but patients receive up to 3 self-administered supervised injections of either diacetylmorphine or hydromorphone. In the study, there were about 100 in each group, and there's still just under 200 patients at that clinic. During the study phase, they found that hydromorphone was not inferior to diacetylmorphine, and the primary outcome measure that they used was reduction in illicit heroin for the treatment of opioid addiction. And again, it's that small group who hadn't responded to other treatments. So I think because of less restrictions that are available for hydromorphone compared to diacetylmorphine, expansion of injectable opioid agonist treatment is a really important area for nursing advocacy, research, and practice. We need to really look to expand the entire evidence base for treatments for opioid addiction across Canada, and especially with injectable treatments for really the people that have not responded well to any other treatments and really, really need this type of approach. So we reviewed kind of the guideline and the different areas, and so feeling like we know that the evidence, the next sort of piece is to really reduce stigma as a nurse in nursing practice. And there's some kind of key areas that nurses can really focus on, and one that I wanted to highlight is really language. And so the BC Centre on Substance Use guidelines use the preferred terminology of opioid agonist treatment. So we don't use OST or opioid substitution, we don't use ORT, and really that's to sort of combat a sort of commonly held belief that these medications are just to replace another substance, and it's not actually an evidence-based treatment, and that's not true. So medicalizing that term and saying this is an opioid agonist treatment, which is the mechanism of action of the medication, it kind of takes that sort of shame and blame away. Another kind of medicalization term is to talk about opioid use disorder, opioid addiction using, again, medical terminology. It's 2017, we have the DSM-5, so opioid dependence was kind of an older terminology using the DSM-4, and we definitely want to stay away from opioid abuse or misuse because, again, that's stigmatizing, and we want to talk about these in medical terms because we're medical professionals and we're treating a chronic relapsing condition. Another way that we can reduce stigma through language is to always use people-first language. So, for example, it's much more appropriate to describe somebody as a person with an opioid use disorder rather than an addict or an opioid user. Avoid slangs and idioms. And this one's so common. But, you know, don't say things like druggie or crackhead or junkie. Those are terrible things to say about your patients. And it also includes the way that we avoid referring to the way that we test urine. So in addiction care, we use urine drug screening or urine drug tests. And, you know, people commonly say that's dirty versus clean. And again, that's a value-laden judgment. So don't use dirty versus clean, use positive versus negative. Another key piece is to really use language that promotes recovery. So recovery-oriented language refers to using terms that conveys kind of hope and optimism and supports recovery and should be the standard for all healthcare professionals that are working with patients and families with addiction issues. So some examples are avoid using terms like unmotivated and non-compliant or non-adherent, as this suggests to other healthcare professionals that the patient is resistant to treatment and sets the person up for failure. So instead, you could use language that attributes sort of personality and refers to the practitioner, and phrases such as, you know, they're not in agreement with the treatment plan or they opted not to do this, which really recognizes the individual personal preference and the patient autonomy in guiding their own treatment and their own recovery path. So another really important piece, and again as nurses, is to really integrate a harm reduction approach across the continuum of care. And again, if we look back in that diagram that I showed you earlier, you'll note that harm reduction is the foundation of all of the care that we provide. So no matter when people are getting withdrawal management approaches, opioid agonist treatments or therapies, or specialist-led approaches, harm reduction is sort of the underpinning and the support that is always there for people when they need it, if there's a relapse or anything else occurs, that they really need to ensure that those approaches are really included across the continuum of care. And for opioid addiction, similar to HIV and hepatitis C, it's an interesting condition because when you treat it from the medical standpoint, it's also a public health intervention. So especially for people that use injection drugs, so looking at it from that lens can be an interesting way to frame it for patients. people are likely aware, and depending on where you're coming from, hoping you have access to a provincial naloxone distribution program. But really, when I'm talking with people, I always say naloxone is like an EpiPen, and it really needs to be out there everywhere for everyone. Anybody that uses opioids, they know somebody that uses opioids. They're on a lot of pain medications for chronic or acute pain. These just need to be out there because we know through the evidence that the more kits that we can actually get out there, the more that we can reduce the overdose rates. So if you don't have naloxone training, you can work to advocate for that in your area or to ensure that that's available in your community or acute care setting. Another key piece is having access to supervised drug consumption sites. And I think it's really important for nurses to be able to have an intellectual conversation with people in their community about really what supervised consumptions are and what they are not, because I think there's some commonly held misbeliefs out there. So really what they are is it's a place where people can inject pre-obtained drugs. So you don't get drugs at these sites. You come in with your own drugs, and it's a supervised setting, so there's healthcare professionals and peers and other people there that can ensure your safety in the case of an overdose or any other concern. It's a place where harm reduction supplies are provided, so clean needles, tourniquets, alcohol swabs, kind of you name it, they're available and to be used. Staff are there and they're equipped and trained to treat an overdose. They can educate and help provide information on safer injecting practices, so people can ask them questions and they can help people to find a vein or to think about safer routes of administration. And a really important piece, and we know through the evaluation of Insight, which is North America's first safe injection site, is it does connect people into treatment. So Insight actually has a little primary care area where people have kind of abscesses or other primary health concerns that they would like to be treated and see a nurse. They can see them on site, and if they are interested in addiction treatment, then they can be referred. So it's what it is not, and again at Insight there's kind of like a bill of patients' rights that are up there right on the wall for everybody to see that the community put together, because again it's really important to say what safe drug consumption sites are and what they're not. It's not a place to purchase drugs, so dealing drugs is not tolerated. It's not a place where the government supplies individuals again with drugs. It's people obtaining pre-obtained drugs and injecting them. It's not a treatment facility. It's a safe consumption site. And it's not a place where other people inject you with drugs. To go there, you need to be a self-injector or be able to really administer that medication yourself. So the last piece that I want to talk about before I turn it on over to Al is a real opportunity for nurses to be a leader in the area of substance use and addiction. In my opinion, historically, it's always been mental health and addiction, and addiction's been kind of the bad stepchild of mental health. Mental health is such a huge area and requires such a dedicated focus that sort of adding on addiction there kind of dampens it down, and we really need to support nurses and the healthcare system in really recognizing addiction as a key area of focus. And so one really interesting area is that in November of last year, I had the opportunity to go visit Boston Medical Center in the U.S., and they're really doing some very innovative things around advanced practice nurses and also around what they call office-based opioid treatment with buprenorphine. And really what this is a totally nursing-led model. So they have, once patients come in, they're assessed by a physician and determine the treatment plan they want to go on, again, and that's in consultation with a nurse. Then they see their primary care doctor every 4 months, and a care team of 5 nurses and a couple of nursing case managers can care for 700 patients on buprenorphine, which is just amazing because it's a obviously evidence-based way. You can really protocolize this type of medicine. Some of the studies that they've done as patients really show improvement, and they really enjoy interacting with nurses on kind of these weekly visits and weekly basis. And I think it's an important model that we could look to in Canada to increase access to evidence-based treatments and care. And I just wanted to say it's not, again, only for just opioid use disorder, but there's a way that we can look at it a little bit more upstream. And again, this is from the Boston Medical Center, where they have a program there called Top Care, which is sort of looking at problematic prescribers in their electronic database. So people that are prescribing maybe too many opioids were actually randomized to receive a nurse that could do what they call academic detailing. And so the nurse was there as an assistant, and they could kind of play the bad cop and talk with the patient around different medications or other treatment modalities that they might have not tried. And there were some really positive outcomes in terms of decreasing the amount of morphine equivalents or the amount of opioids that patients were on for acute or chronic pain. But as those opioids went down, patients' pain scores also went down. So such an interesting piece that can actually kind of be a little bit more upstream to help patients manage their chronic pain in a different way, but before maybe there's some concerns that could lead into substance use disorder. Another piece that I really wanted to highlight, and I don't know if we have any nurse practitioners on the call, but I think there's a real opportunity, and BC is finally moving on this, and sort of in light of our provincial opioid overdose crisis, is right now in BC, nurse practitioners can prescribe Suboxone, and moving on to full opioid agonist treatment, so methadone, and then continuation and initiation of those medications in the summer. And so, you know, wherever you are, I think Manitoba and Nova Scotia have some similar practices, but this is another key area. We need more prescribers, and we need more trained prescribers to treat addiction in our communities. And another key piece I just thought I would say is, again, this is a BC little bit focused piece, but I think, you know, I had the pleasure of participating in a panel for the BC Coalition of Nursing on an opioid forum in December, just around what's happening in BC and how fatigued nurses are and burnout, and they're just really not feeling like they're prepared to treat addiction, again, in this really horrific crisis that we're experiencing here. So, you know, I would encourage people to join their local coalitions or nursing associations to learn how you can best support each other in times of a crisis and for educational opportunities related to substance use and addiction. And as another little bit of a plug, the BC Centre on Substance Use has the only Canadian addiction nursing fellowship program for which I lead, which is a really interesting interdisciplinary program that has a physician stream, a nursing stream, and a social work stream. And so this is really for nurses to improve their clinical knowledge, but also for leadership, research, and advocacy related to addiction to really position nurses as leaders in their field and in their area of employment for addiction nursing specifically. So if you're interested in that program, you can go to the BC Centre on Substance Use website or contact me after the webinar. There's the website there. And another sort of key piece is, I think, again, I kind of alluded to this, but in Canada, we really miss the opportunity to include addictions training for all healthcare professionals, I think specifically nurses. When I was in nursing school, I got 3 slides on addiction in a mental health class in a 4-year degree program. So that's just really not enough, because we see addiction in every area of our nursing practice, in community, acute care, prenatal, primary care, you name it, it's there and it's across the board, and just really feeling underprepared as a new graduate. Again, we really need to look for other opportunities across the continuum of sort of practice and education to ensure that there's support for nurses in their training when they're in school, but also postgraduate training opportunities. And so I think this is a real area for nursing advocacy for people to do. There's a few pieces here that I co-authored or authored with one of my colleagues, Pauline Boone, just around these sort of areas and really the important role that nurses play in caring for patients and families with substance use disorders. There's another one. All right, so I'm just going to hand it over to Al Fowler, who's the president of the British Columbia Association for People on Methadone.
Hello, my name's Al Fowler. I am the current president of the BC Association of People on Methadone, which is heard 4 times already. So I'll just give you a quick overview of how I got involved with the methadone program. In 2010, my wife and I moved to Vancouver from Vernon. At the time, there was zero housing in Vancouver, so we were staying in a shelter. I heard of a friend of mine. He said that there was a place we could go live if I was on methadone or she was. So I went on methadone specifically for that. So this is where this is where the recovery houses and stuff comes into play, because most recovery societies will not accept people on methadone because it's still considered a narcotic in their terms. So it's really hard to get help that way. And this the recovery society that I was involved with, they were actually really shady. You know, we had to get our methadone delivered from the pharmacy of their choosing, not our choosing. And it says right on the script itself, not for delivery. So that kind of put up some flags. Well, anyway, it was real shady because, you know, most recovery centers, societies, you know, sober houses, because they're not under the Tenancy Act, they can just basically evict you at any time if they think you're using or whatever. They can just evict you, and that's how that one was. But with the help of City Council and Pivot Legal Society and BCA Fund, we managed to get rid of that guy. So in BC, it was a big crisis for a while because it was seen as a cash grab. So a lot of methadone patients just felt like, I don't know, like we were just a commodity, you know, because each pharmacy is getting paid so much for daily witnessing and all of that. There's a lot of money involved. So we have to be really careful on that. I won't go to detox. Let's start there. People who go into detox to do the quick 14-day, you know, under nurses' care, you know, medical care to kick. Like Cheyenne said, if there's no interaction or no services in place for after you leave detox, well, you're looking at 90% chance of relapse. And in Vancouver here, BC, with the fentanyl crisis we have, you're looking at probably a 75% chance of a fatal OD. So that's a hard one. But the buprenorphine for withdrawal treatment, I'd say that would be good for, you know, young people in their early 20s, recreational users, because it like Cheyenne said, it's a short burst to get to a proper level of medication to help with your withdrawal. Whereas, you know, methadone, it take up to, you know, a month and a half to reach a stable dose. And I brought my wrong notes with me today, so I'm a little confused. Sorry about that. So let's go on to. So I talked about the thing with stigma. Let's go on to stigma. The thing with stigma is, like, you know, like Cheyenne said, you know, calling urine test dirty, you know, or clean. Like that's the thing. And we find that the methadone program, the way it's set up, it seems to be really punitive. You know, like most cases, when your doctor is seeing you're having trouble struggling through your illness or whatever it is, they tend to help you more. But it seems in the methadone program, if you're struggling, you know, still using once in a while, it seems that you're just kind of cut off and fed to the wolves. So that's really something we need to work on, because, you know, we're working with people, not just numbers and statistics. And I think once the BC Centre for Substance Use takes over the methadone program from the doctors, the College of Physicians and Surgeons, I think we're going to see a difference. And I lost where I was. What was I going to say? Okay, I don't know, I totally lost you. I'm a little messed up this morning. Okay, so yeah, with the methadone program as it is, it's not that bad, but I would like to see, you know, more of the injectables and stuff, which is going on at Crosstown Clinic, because it's really funny. I know a lot of those people, and they've been doing that for a year, and they're like 3 times better than I am with being on methadone for 7 years. You know, a lot of them have reconnected with family. They're you know, they're back to working, and just, you know, their lives have just got better. And I'd like to see that program expanded, you know, which we talked about. But yeah, the major thing is the stigma and treating patients with care, because when a patient does come in and say, look, I need methadone or something, they're vulnerable. They're at a position in their lives where they've, you know, probably hit rock bottom, whatever. And they need compassionate care, not just, okay, wait here, we'll see you in an hour or whatever. Because, you know, most times when you go to your methadone doctor, most methadone doctors don't take appointments. You know, they say, okay, well, I'm in between 2 and 4 o'clock, so you just got to go in there and wait. So, you know, every time you see your methadone doctor, you're wasting, you know, half a day usually, which is, you know, anybody else, you know, if I take a half a day off work every 2 weeks, like eventually I'm going to lose my job. So we need to loosen it up a bit, but it's kind of hard. You can't loosen it up too much, because then you have the redirection of the methadone, or, you know, stuff like that. So I just hope that, you know, the nurses just use compassion when treating, you know, people with opiate use disorders, you know, because we are vulnerable people, and a lot of people, they ended up in these situations because they were hurt at some point, and a doctor has put them on, like, say, Dilaudid or morphine or whatever for pain, without having a proper exit strategy for that person. What I hear a lot of is people, because with the whole opiate crisis, the fentanyl crisis we have going on in BC, a lot of doctors pulled a knee-jerk reaction, and a lot of patients were cut off their meds or cut severely back, which has sent them out to the illicit market. So, now I've lost my train of thought. So the thing is we need to give the proper medications to the right people. You know, we're downtrodden, we're stigmatized. We're stigmatized as drug users, as, you know, junkies, dirty people, can never do anything. So when you go to ask for help, you really like to get help. I don't know what else more to say.
Maybe the only thing, Al, is I know we've talked a lot about this, and the kind of umbrella organization VANDU that BCACOM is under. Their kind of one of their mottos is nothing about us without us.
Yeah, nothing about us without us. That's our motto at VANDU. And VANDU is the Vancouver Area Network of Drug Users. And they're an organization. Some of the umbrella organizations of them is BCACOM, is the Eastside Illicit Drinkers Group. There's the Western Aboriginal Harm Reduction Society, and there's, I think there still is Crystal Meth Group. I'm not sure on that. But it's places like VANDU that give users a voice, you know, that we are actually really people, and we can function normally, you know. It's no different than, you know, in my eyes, it's no different than the guy who afterwards, you know, has a couple beers or, you know, stuff like that. And with the whole fentanyl crisis, that's right along the lines that prohibition was with the alcohol in the early 1900s. There's a lot of criminal involvement. There's a lot of people dying, a lot of people going blind, which is what we have now. So if we had, I don't know, if we had other options, like what is happening at Providence, and, you know, with the crosstown clinic there, that would really be good. Because there's only 140 people, and there's thousands of people in BC on methadone. And this new methadose, it does not have the length of time to stabilize. I'm saying that wrong. It doesn't last long enough. It metabolizes too fast. Like, I'm on a split dose myself, but my dose only lasts for like 8 hours. So what's happening is I'm basically spending 8 hours a day in some type of withdrawal. And it gets hard day after day after day. The old methadone was fine. The formulation was changed without much consultation as far as we were concerned. So But all I can say is just treat your patients with compassion and care, and they're, somebody's mother, brother, sister, father. So thank you for your time.
And thanks so much, Al. I think it's such an important, and that sort of nothing about us without us, I think is something to keep in mind is when you're planning care, when you're treating people, and, in my nursing and clinical care experience, where I've learned the most is from my patients and from their families, and they have such valuable insight and experience to really have autonomy over their care. And, as Al said, when you really just treat people with care and compassion and kindness, especially in substance use and addiction, it makes such a big difference. And so I think really just to summarize what we talked about in those key areas, so again, know the evidence and really let the evidence guide your treatment planning and care as part of an interdisciplinary care team with your patient's prescribers.
Yeah.
But make sure you integrate patient and family education, and again, goals and treatment are all patient-led. If it's your goal and what you're thinking your patient should achieve, it's not going to work because it's not really coming from them. And so really integrating patients and families into care with education around treatment is super key and such an important role for nurses. Again, reducing stigma, using that language, promoting recovery, and really being an advocate for your patients and community, and wherever appropriate, as Al said, engage with patient organizations for people that use drugs in your area for program planning and guideline documents and pieces like that. For nurses, again, integrate that harm reduction approach across the whole continuum of care for opioid addiction. So again, it's that foundation of the care that we provide, ensure that there's naloxone available, and really be advocating for safe drug consumption and safe injection sites in your community, and be a leader. There's a lot of areas for nurses. I'm always kind of trying to sizzle addiction nursing because I think it's such a great area of practice. And for different models of care, so really for people that do administration, people that do policy, and people that do research, there's really something here for every type of nurse and nurse leader. And just wanted to highlight a couple of resources that are available for you as well.
Something before
Sure.
you do that? I just want to say that any person who is prescribed any type of opiate, they should be told about naloxone and given a kit and given a course on it, because you never know. Little Johnny comes over to grandma's plate and finds something in the medicine cabinet and takes it, right? So,
Yeah.
So that's something to kind of impress on people. Okay. Thanks.
So I guess if you have some questions here, you can type your questions in the text box at the bottom of the QA window, then click the text bubble button on the right.
Thanks, Cheyenne. For reading that last slide. Thank you to Cheyenne and Al for the robust presentation. We have a few minutes for questions, so I'm just going to address some of the questions that we have in the short time allotted. What is the evidence for opioid agonist treatment in youth and adolescents?
So that's a really good question, and I think the guideline that we talked about, it really does cover youth and adolescents. And again, it's really looking at that continuum of care with a very detailed substance use history. In British Columbia right now, because we're in an overdose epidemic, my opinion is really anybody that has an opiate use disorder, kind of moderate to severe, that's the youth, medication approaches can be very, very useful to really just protect them from that overdose risk, as we know that the street drug market is really just filled with fentanyl and fentanyl analogs like carfentanil. So it's really about weighing sort of safety and treatment, but again, the guidelines that are out there apply to youth and to adolescents as well.
And with youth, we're finding it's really hard to get some type of harm reduction supplies to them because it's seen as contributing to minors. It's really looked on bad. So that's the thing, is to try to, get the harm reduction out there to them.
Thank you. And we have a question. Is there any difference in treatment for people who use primarily prescription opioids versus illicit opioids?
Yeah, there isn't, and Al's right, and this is a common sort of misconception, I think, out there, or it is also for people that might use more heroin than somebody else or more prescription opiates. really the evidence is equal when we look at opioid agonist treatments like methadone and Suboxone. So again, it really needs to be taken on an individual basis with the care provider, but we know that from the evidence that the best for long-term success is really from opioid agonist treatment maintenance. So choosing whether or not Suboxone, it's recommended as a first-line therapy, is that the best medication? See if it is, and if it's not, then methadone, and then up the treatment continuum to higher intensity care when it's needed.
And what we're finding is people who are prescribed opiates, and then they get hooked. I hate to say it that way, but then they, then they go in for help to try to kick this. They are not the same as somebody else who's, hardcore into the scene like I used to be. So you kind of have to treat them a little bit different than your usual patient, but because people who got their drugs from the doctors, they don't see themselves as addicts, right? They're just looking for help. So yeah, it's got a lot to do with the stigma again there.
Thank you. And we have a question about what is the average length of time for an individual to be on the methadone program, and are they able to be weaned off this program over time?
Mm-hmm. So that's a great question. Lots of patients always ask when they start is when they're going to get off of this type of stuff. And really, when I'm chatting with patients, sometimes I use a common medication or something like an antidepressant. And when people go on that, sometimes we don't know if that's going to be a year, if it's going to be 5 years, if it's going to be 10 years, if it's going to be the rest of your life. It's really as long as you need it. It's really recommended that because addiction is a chronic relapsing condition of the brain circuitry, memory, and reward, that really it takes almost a year for the brain to really heal. Yep. And so we recommend at minimum 1 year, and then really going super, super, super slow on a taper. So we know from a lot of evidence in British Columbia that the faster you taper people, you're just setting them up for relapse and kind of for failure. So doing a long, slow taper, and again, this can be over a year or more, and stabilizing when people need it. If you feel like you're coming down too fast or something's coming up in their life where they're not really feeling like this dose is holding them, then holding that dose for a number of weeks, even months, and then continuing that super gradual reduction is the best way to go.
Yeah, on that vein, from what I've read and what I've been told, they say it should be a 3 to 5 year program. Like Cheyenne said, takes the first year to kind of get stabilized, get working properly. Then the doctors like to have about another year where you are stable and getting better, and then start to do the taper. But I've known people that have been on methadone 20 years, 15 years. Like I've been on 7 years now. But I had a bit of a relapse in 2014 when the formulation was changed from methadone to methadone.
Great, thank you. And we also have a lot of feedback. I just wanted to mention a lot of thanks from participants, thanking both of you for your presentation, and specifically Al, thanking you for sharing your lived experience. And I just wanted to mention that. So,
well, I feel privileged to be involved in stuff like this. And my email address is up there if anybody wants to, email me and get to know, learn more, or whatever, or just to chat, I'll be there.
Wonderful. So as Al mentioned, his email address is there, as is Cheyenne's, and as is mine. So thank you again, Al and Cheyenne, for your presentation on opioid agonist treatments. We hope that this session stimulated our participants thinking about nursing practice. And I just also wanted to mention, if you haven't already, please consider registering for the next webinar, Supervised Consumption Sites, Where Are We Now?, which will be held on Tuesday, May the 2nd from 3 to 4 Eastern Time. And that information is also available on CNA's website. So thank you so much for your participation today. And I'd like to sign off and say goodbye.
All right. Thank you very much.
Thank you, everybody.
Thank you.